Yeah, we are live.
Okay. So I'll admit everybody from the waiting
Yes,
hall.
please do.
I think so. We are good to go.
Please proceed, Nilesh.
So
Yeah,
I'll
go
just
ahead.
share my screen.
Nilesh and Devakant, just click on the option and mute participants on entry.
Yes, sir.
I have done it. Okay.
Okay. So I'll start, sir.
Please do. Please do.
So, welcome to the annual YoSlides Award 2020. This is the grand finale we are hosting on 10th of January today. And I will just 1 second. So I would like to thank the YOC Governing Council for providing us this opportunity actually to start with your slide. It was just, I think, a WhatsApp message with the Governing Council and it was approved. So it starts as an YOC initiative to provide the residents and fellows a high quality of comprehensive overview of a particular topic via self-explanatory PowerPoint presentation. And it was, everything was selected, and then it was published. In last 5 months, we had over 20 curated and reviewed presentations with more than 3,000 plus accesses and a dedicated web portal to do that. Courtesy island.in, where the June DNB questions were published, we could see that 70 marks worth of questions were directly from the 20 published slides. So that's the importance of curated presentations. So now we are coming up with dedicated social media handle for a wider outreach. We have a dedicated web page, and now we are starting with the public education platform as well, where we will have the first will be glaucoma awareness as called by AIOS. So everyone can email their submission to your teamyourslides@gmail.com for the same. So out of the 20 submitted publications, it was a daunting task, and Dr. Aditi ma'am, Dr. Krati ma'am, and Dr. Saurabh sir, they did a marvelous job to finalize the 6 finalists that are going to present today. So Dr. Aditi Ghosh Dastidar is a cornea and ocular surface specialist who has done fellowship in cornea, cataract and refractive services from Medical Research Foundation, Shankar Netralaya, from 2014 to 2017, and was associate consultant in the Shankar Netralaya Kolkata branch till 2020. And now she is consultant in charge of cornea and ocular services at Batra Hospital and Medical Research Center, New Delhi, where she is working on stem cell research. She is an active member of surgical skill transfer course of AIOS and YOC. She has also, to her credit, multiple publications in national and international journals, and she has delivered faculty talks and presented papers and posters in various national and international conferences, winning Best Paper Cornea in DOS Annual Conference 2019 and KP Roy Annual Award finalist in OSW, that is West Bengal Annual Conference 2020. So we will like to have comments from Dr. Aditi ma'am, how she felt about picking up the finalists.
Thank you, Nilesh, for the kind introduction. Thanks, Team USC. You all have done a fabulous job. And I think it was very difficult for the three of us because the presentations were so good. The content, the references, the way it had been presented. Actually, at one time, I was actually feeling I wish I was a PG doing my MS right now, because that time I think we used to have slide share and we used to dig up so much to make a presentation, going to the libraries, and so crisp way of presenting in every slide. Thank you so much. I feel honored to be a part of this process. Thank you so much, Nilesh.
Thank you, ma'am. And then we had Dr. Krati Gupta. She has she's a super achiever, currently pursuing cornea and refractive surgery fellowship at Narayan Netralaya, Bengaluru. And she did DNB from Sri Shankar Dava Netralaya, Guwahati, and MBBS degree she holds from Maharashtra University of Health Sciences. She discovered a new clinical science, that is triangle science in eye. That was the iWiki winner in 2019, and she was runner-up of annual AIOS Think Under the Apple Tree 2020. And she has published over 45 papers and is an active reviewer for Indian Journal of Ophthalmology. And she has also been invited to deliver talks at AIOS and Keracon. And she's an active member of Corneal Society of India, YOSI, and AIOS, and Ophthalmic Society of Assam. She has also been part of multiple webinars and teaching programs, including iFocus Online and iCoach. And she has presented various papers in various conferences. And she is founder and editor of the website ilearn.in, which is a go-to website right now for any DNB or exam-related queries. So we will have her words.
At first, I would like to congratulate Nilesh, Dr. Nilesh, on his fabulous work that he's been doing to reach out to fellow ophthalmologists and juniors and making their task of reading very easy. And immense thank you to Divakant sir and team Yosi to have come up with such innovative idea to help the youngsters. All of the presentations were very good, very nice, and pertaining to the topics which are very relevant for the postgraduates. The most important things that I tried to streamline in order to at least get the finalist was how was the format of the presentation? Was it covering all the relevant subtopics which are asked in the exam? How lucid are the presentations? Because the theory is always there in the book, but it has to be presented in a lucid format for the student or the pupil to understand. So your presentation should be self-explanatory. The diagrams, which are very important when you are trying to fetch those extra marks and save on your time by not writing the theory, and also the references provided at the end of the presentation. Some people want to read further, so it's very easy for them to go back and find out how they can have a further reading on the same topic. Another very impressive thing that I found in these presentations was the handout. That was my go-to for these presentations. And they are your automated notes, which the student might have to make from the presentations. So they were already done. So that was a very good thing. Thank you for making me a part of this initiative. It was very, very nice experience.
Thank you so much, ma'am. The handout was idea of Dr. Apurva, ma'am. She insisted that we had an handout before with each presentation. And now the third and final judge was Dr. Saurabh Deshmukh, who is also founder and editor of iLearn.in, and he is currently pursuing long-term vitreoretina fellowship at Sri Shankar Dava Netralaya, Center of Excellence in Eye Care. He has published extensively in various journals like JAMA, EJO, IJO, etc. And he has won many international and national awards, including AAO, IVK International Ophthalmologist Award, Star of India International Ophthalmic Hero of India by AIOS, Young Researcher Award by TNOA, and Dr. K.R. Dutta Best Paper Award at ISOC, among others. So we will like to have his words also before we proceed.
Thank you, Dr. Nilesh, for the kind introduction. First of all, I would like to congratulate you for the YoSlides initiative. And I'm extremely grateful to Dr. Devakant sir and Yosi for the opportunity, for getting me the opportunity to judge these amazing presentations. So when we first went ahead with the presentations, it was very difficult because all the presentations were very well made and they were very well made by the well-read individuals. So it was quite difficult initially, but then there were a few points which helped me in judging these presentations. So first one was the quality of content which I looked through. The first one was the content. So content was, it has to be quite relevant to the topic, and the presentation had to be quite concise, because if the slides are too messy, it is very difficult for the individuals to read and also grasp the topic. The second point which I considered was the quality of the slides, because you cannot have too much content on one slide, and also the font which the person used, because it has to be legible. Because initially when you start reading the topic and the font is not legible, that is also one of the points which I considered. And also the size of the fonts, because if you keep on changing the size of the font, it becomes quite cumbersome to read and understand. And the third point which I went through was the quality of the handouts, because as rightly said before, these are quite important and can be used as the notes when the students prepare for their theory exams. That was one of the point. And the fourth one which I considered was the diagram, because many times we use these diagrams which are given in the presentation and we draw these in the exams also. So how easy was it to draw that diagrams in the exam? So in the end, best wishes to the finalists, and may the best presentation win. Thank you.
Thank you so much, sir. So now we'll move ahead and just. So now it is my proud privilege to present the core team of your slides that is going to take the your slide forward in coming future. Dr. Sheikh Abdul Aziz, who is a PG resident at NMCH and RC, Raichur, Karnataka, will be the first your slide member. Dr. Ankita Aishwarya, MS FICO MRCS Edinburgh, who is current fellow in ocular oncology and oculoplasty, who has won Best Paper Award at AO 2020 and Best Outgoing Student and Gold Medal in 2019, and Dr. Ramesh Krishna Agrawal for Best Poster in 2018, and she is 3-time consecutive winner of National Quiz from 2017 to 2019. Dr. Anupam Singh, who is doing his PG right now from Regional Institute of Ophthalmology, Eye Hospital, Sitapur. Dr. Ayushi Agrawal, who is pursuing final year of residency from Guru Nanak Eye Center, Mamsi, and has won Best Free Paper Oculoplasty and Ocular Oncology consecutively in DOSCON 2019 and 2020, and Best UO Flash Note Award 2019 at AIOS Forum, and presented several papers and posters in various international conferences. Dr. Kaushik Tripathi, who is a consultant retina, uvea, and cataract at ASG Hospital, BT, Kolkata. Dr. Muskan Bansal, who completed her MS Ophthalmology from PGMIR Chandigarh in June 2000, and 3 months of senior residency from AIMS Bilaspur, and presently pursuing MCH Cornea, Cataract and Refractive Surgery from PGI since 1st January. Dr. Neelam Khatwani, secondary DNB resident, final year from Sant Paramanand Hospital, New Delhi. Dr. Rakhi Dicruz, secondary DNB resident from LVPI, Bhubaneswar. And me, Dr. Nilesh Kumar, consultant at Ayodhya Eye Hospital, Ayodhya. So this is the USLIDE team which will be going forward for the next year. And now I would like to invite everybody for the grand finale, for which we all have gathered. So introduction of judges will take place from the newly inducted team USLIDE. So Dr. Abdul will start the introduction. Dr. Abdul, please unmute.
Good afternoon, everyone. Dr. Digvijay Singh is our first judge. He is MD, FA, CEO. He has special interest in pediatric ophthalmology and strabismus, neuro-ophthalmology and glaucoma. He holds to his credit 20 awards, 75 publications, 20 books, chapters, 1 book, and 60 abstracts in proceedings. He has delivered over 100 lectures in 8 international and 16 national and 24 state conferences, apart from virtually delivering over 20 lectures in webinars. He has great interest in technology in eye care and is the co-founder of a technology company, Kalpa Innovations, where he has developed an artificial intelligence tool for glaucoma diagnosis called RAIG. He is a research guide, co-guide, and advisor to over a dozen students from different universities across the country. He is currently president of Young Ophthalmologist Society of India and treasurer of Indian Neuro-Ophthalmology Society. He is a director of Noble Eye Care Gurugram. He is head of the Department of Ophthalmology at Narayana Super Specialty Hospital, Gurugram, head of the department Madhukar Rainbow Children's Hospital, New Delhi. Welcome, sir. Dr. Sona Kalia ma'am, she is a gold medalist. She is presently assistant professor in upgraded Department of Ophthalmology, SMS Medical College, Jaipur. She is also vice president of YOSI, India, executive member of Jaipur Ophthalmology Society. She is an anterior segment and glaucoma surgeon. She has done her undergraduation from JN Medical College, AMU Aligarh, and her post-graduation from SMS Medical College, Jaipur, and 3 years of senior residentship from the same SMS College, Jaipur. She is selected via RPSC at first rank in state as Assistant Professor Ophthalmology and joined as Assistant Professor in 2016 June at SMS Medical College, Jaipur. She is AOS LDP alumni. Welcome, ma'am. Dr.
Good evening, everyone. Good evening, everyone. It is my eminent pleasure and honor to introduce Dr. Divakant Mishra, who is a vitreoretina surgeon, ocular oncologist, and ROP consultant, currently working at the IQ Super Specialty Eye Hospital, Lucknow. He is trained from the Bayes Institute, Stanford University, US, and Sri Nitale, Guwahati. He is also appointed as the visiting faculty at the Thessaloniki International VR School, Greece. He is the recipient of the various international ophthalmic awards, including the Achievement Awards by APAO, Ophthalmic Hero of India in year 2018, 2019, 2020, Star of the India Awards 2020, APVRS Award, and the IGO Best of the Best Awards. He has 30 publications and book chapters in his name. He is also the reviewer of the PLOS1, IJO, IJCEO, and he is also the invited faculty of the AAO, APAO, URETINA, and ESCRS. Welcome, sir. It is my great and with honor, I like to introduce Dr. Karan Bhatia. He is my mentor. He is an excellent cornea cataract and refractive surgeon. He is currently serving as the head of department cornea, consultant and the assistant professor at the Regional Institute of Ophthalmology, Sitapur Eye Hospital, Sitapur. He is also the joint secretary of the UC. Welcome, sir.
It is my privilege to introduce Dr. Apurva Ayachit. She is currently a consultant in vitreoretina in MMJC Eye Institute, Hubballi. Her interests include macular imaging and vitreoretinal surgery. She is currently the academic head of UC India, and she is also working as an assistant editor in the retina subspecialty for Indian Journal of Ophthalmology. Welcome, Dr. Apurva. And it is a privilege to introduce Dr. Avanish Upadhyay, who is the brain behind the very successful late night retina series of UOC. He has done his DNB and fellowship in vitreoretina from Little Flower Hospital, Angamali, Kerala. He was a consultant at Sri Sankaradeva Netralaya, Guwahati for 2.5 years, and he is currently working at IQ Super Specialty Hospital, Gurugram. His interests include imaging, retinal imaging, and macular disorders. Welcome, Dr. Avanish.
Thank you, Dr. Kaushik, and I welcome all the judges, and I'll just quickly go through all the rules before we start the presentations. So each presentation will be for 6 minutes, followed by a question answer session for 4 minutes, where 2 lead judges will lead the question answer, and any judge is free to ask as per their will. Total mark for each presentation by each judge is 50, and all judges will be marking all the presentations. The total weightage for audience vote is 50 marks for first, 40 for second, 30 for third, 25 for fourth, and 20 for fifth and sixth in the audience poll. So total marks up for grab for each presentation is 350. For exceeding time limit, 10 marks every 10 seconds will be deducted. So please be on time. And the 10 points in which the presentation is going to be judged is understanding of the topic being presented, confidence of the presenter while presenting the slide, clarity of the presenter while speaking, was there a flow in that abridged version of the slides, appropriate use of audiovisual aids and relevant to the topic, the quality of reference material, the aesthetic quality of the slides, the optimal content on each slide, the ability to answer the question, and the scientific content in the impromptu answers. So these are the rules. So let us introduce today's star. This will be Dr. Rakhi. Can you please introduce Dr. Ashwati?
Hi everyone, a very warm good evening to all. So today I'll be introducing the finalists for this session. The first one is Dr. Ashwati Neena Satish, who has done her MBBS from KMC Mangalore, and she is a current final year resident of MS residency from Jipmar, Pondicherry. And she had made wonderful slides on the topic of keratoprosthesis, which was selected for the final. Congratulations, Ashwati.
Dr. Ashwati, please share. The lead judges for this presentation are Dr. Digvijay sir and Dr. Devakant sir.
Good evening, all. Are my slides visible?
Yes.
Okay. So thank you for the warm introduction. So today I'll be presenting on keratoprosthesis. So I am Dr. Ashwati. I'm doing my third year PG graduation from JIPMA. So keratoprosthesis have always been a daunting topic to me as a postgraduate. That's why I chose this topic. So the concept of a keratoprosthesis is to create a window of transparent foreign material in a severely damaged or diseased cornea in a patient with visual potential. So now to understand the keratoprosthesis a little, the components of the keratoprosthesis include the optic, the haptic, and a surface covering. The optic is most often made of PMMA, which is a central cylinder which allows transmission of light. And then the haptic is a support system which can be biocompatible like PMMA or biointegrated like a Dacron mesh or completely biological like a tooth or bone in osteodontokeratoprosthesis. Now what is to be understood is the difference between type 1 and type 2 is that type 2 always has a covering to it, a surface covering. That's usually a skin in type 2 Boston keratoprosthesis, while it's buccal mucosa in osteodontokeratoprosthesis. While in type 1, we have to always use a soft contact lens. So coming to the indications and contraindications. So the main thing to understand is that a patient should be monocular or functionally blind in both eyes to be considered eligible for a Boston keratoprosthesis. And the main thing is that it's not an alternative for keratoplasty. It's only a last resort for your corneal blindness. So taking type 1 keratoprosthesis in decreasing order of prognosis, the indications are multiple failed grafts, aniridia, herpetic keratitis, silicone oil filled eyes, and pediatric corneal conditions. Further down the line, when the eye becomes more dry, you will go on to a type 2 keratoprosthesis. So the type 2 will be used in Stevens-Johnson syndrome, ocular cicatricial pemphigoid, chemical injuries, and severely keratinized surface. If you try implanting a type 1 keratoprosthesis in such situations, there'll be increased risk of sterile keratolysis and device extrusion. So it's more important to know when not to implant a keratoprosthesis. So in a denying PL patient or a patient with advanced glaucoma or advanced retinal detachments and a patient with unrealistic expectations who is not willing for follow-up and having dense amblyopia, we should not go ahead with the keratoprosthesis. So coming to the type 1 keratoprosthesis, which I'll be talking about briefly. So the type 1 can be an older snap-on design or a newer clip-on design. The snap-on design has three components: the front plate, the back plate, and the titanium locking ring. While in clip-on design, you have two components, the front plate and the titanium ring, which has a slit that allows expansion to fit the front plate. While type 2, the major difference is that there's an anterior extension which allows implantation through a surgically closed eyelid. So the preoperative evaluation in any keratoprosthesis must include a detailed history about the cause and when the onset of blindness, as well as we have to assess the visual potential of the patient, the IOP, the ocular surface status, like I told you, type 1 for a wet eye and type 2 for a dry eye. And then the slit lamp examination and a fundus examination if view allows it. So main thing is to remember that the success depends on an appropriate patient selection. More often than not, we end up relying on a B scan to reveal the retinal status, which is debris, as well as presence or absence of an IOL. The A scan is used to measure the axial length, which helps us calculate the power of the prosthesis. So coming to the procedure, first a donor cornea is refined, which is 8 to 9 mm in diameter, and then the central 3 mm is refined with a dermatological punch. Then the donor corneal donut is placed on the stem of the front plate and then gently pushed down, and then the back plate is placed on top of it, and then the locking ring is placed. Now the next step is to prepare the recipient. First the button is refined, and then iridocorneal adhesions are released. Then a lensectomy is done if the patient is phakic, and then we suture the donor button along with the K-Pro, just like any keratoplasty with 16 to 24 sutures. Then a large soft contact lens is placed. So post-op care, what is important is they have to be maintained on long-term indefinite antibiotics and steroids at least once daily, and they have to always have a soft contact lens which can be changed every 3 months. Now in follow-up, they have to be on follow-up at least 3 monthly throughout their lives. And every time we'll be assessing their visual acuity, refraction, intraocular pressure, slit lamp examination, and possible posterior segment evaluation. So the various complications seen include retroprosthetic membrane, infectious keratitis, stromal melt whenever there's a persistent epithelial defect, and keratoprosthesis extrusion. However, the most challenging always remains glaucoma because the penetration of drugs remains a challenge. And always there's a lifelong risk of endophthalmitis and other posterior segment complications. These are my references, and thank you, your slides, for the opportunity.
Thank you, Dr. Ashwati. She was well within the time limit. Judges, please note. And Dr. Divya sir and Dr. Divakar sir, please go ahead with the drilling.
I think that was very well presented, and I think your slides do say that why you're among the finalists here. And I also welcome all the other finalists. It's very good to have you all on this platform. And this is indeed a tough topic, something that as residents, as fellows, PGs, not all of us will get a chance to see them, or even if we see them, it may be just one-off case once in a very rare while. And while this is getting more and more common, this is something that you all should be aware of. So it is good to have this your slide, and I'm glad you decided to make this presentation, Dr. Asti. So a quick couple of questions that I have for you, and these are going to be, I'm sure most of this stuff you already are covering. So for the OKP prosthesis, right, it's very important for you to have a good tooth. So what is the right tooth that is used for that, and what are the precautions that you tell the patient before you do the process?
In case of an osteodermokeratoprosthesis, the cosmos is entirely different. So we have to counsel the patient with regards to that. And the right tooth is usually a canine tooth because the dentine portion is large enough with a single root for that teeth. So the tooth. So usually a canine is preferred. Yes,
and you always must tell the patient to have a good oral hygiene before that, because when the patient has come in and you're starting to plan the OKP, then you must ask them to get on with a good oral hygiene. Let us say that the canine tooth it doesn't maintain a good oral hygiene and the canine tooth is not very good. Then what can you do? What is the alternative for that?
The next teeth in line would be incisors. And if even a teeth incisor is also not available or poor hygiene is there, we can always go for a osteokeratoprosthesis without a odonto.
Yes, that's right. So you actually have other options. You have the Boston K-Pro 2 type 2 that you can use. You can use the Pin2C. You can use the odonto, where you're using a separate bone. So good, you've done your research well.
Thank you, sir.
Great, Ashwati. So I think you've tackled the questions well. So one question from my side. I'll take the question from the comment first. Dr. Pragya has asked, what will be the criteria for donor cornea in type 1 K-Pro?
So donor cornea, what is advisable is a healthy, newly harvested cornea. But however, if not at all available, we can use the patient's own cornea itself, provided there's no thinning or drastic corneal changes present. Was I audible?
Okay, there was my end. Yeah. So, Dr. Pragya, are you satisfied with the answer? I could not hear it. So, am I audible?
Yes, sir.
Yeah, I think there were some network issues you've been having there.
Now you're audible, sir.
Okay, so one last question from my side before we end. So, can you tell of a potential role in case of a vitreoretinal surgery?
Sir, whenever we are doing a type 2 keratoprosthesis, it's a must to combine it with a pars plana vitrectomy along with the Ahmed glaucoma valve. So that is one way the vitreoretinal surgeon is involved. And very often after vitreoretinal surgery, silicone-filled globes undergo corneal damage and end up with needing keratoprosthesis also. So the cause and the treatment can be described. Yeah.
Right, so we use a temporary keratoprosthesis.
Yes, sir. Yes, sir. Landers keratoprosthesis can be used. Okay, yeah.
Right. Okay. Any question from Dr. Karan? He's the specialist here.
I had the same question that you had just asked. I thought about that. Any Indian models are available? Because the Boston ones are a little expensive and not easily
Yes, sir.
available.
Aurolab has Keratoprosthesis available, which is cheaper. And yeah, it's based on type 1 Boston Keratoprosthesis.
So a good idea would have also been in the slides to have points such as, what is available in our setting, because you'll be giving exams in the Indian setting. And the second, as Devakant had said, the temporary K-Pro could have been also added into the slides.
Yes, sir. I have included it in my handout and my previous slides. Here, time does not permit, so I didn't include.
Yeah, these are the abridged versions of that slide, so that's why. Yeah.
Let's move on to the next, Nilesh.
Yeah. Okay. Thank you, sir, and thank you, Dr. Ashwati, for the presentation. So we'll move on to next presenter, who is Dr. Just a second. Next presenter is Dr. Ayushi, and I would like to clarify first that Dr. Ayushi and Dr. Neelam, who are part of Team Yo Slides, but they are not part of the organizing committee of this grand finale. So they have no control over what was the marking scheme and who all are the judges and how they are going to mark. So, Dr. Rakhi, please introduce.
So next finalist for the day is Dr. Ayushi Agarwal. She's a final year resident at Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi. And her topic for today is thyroid eye disease. Congratulations, Ayushi. Let's go on.
Thank you. Is my slide visible?
Yeah, the lead judges for this presentation are Dr. Sonal and Dr. Abdesh.
Thank you. Thyroid eye disease is a chronic inflammatory autoimmune disease of the orbit. But why and how does thyroid dysfunction lead to the eye problems is a question. And to answer that, we need to understand the pathophysiology of the disease. So the main effector cell is the orbital fibroblast. So the orbital fibroblast and the thyroid share the most commonly implicated antigens, the IGF receptor and the thyrotropin receptor. The autoantibodies against these receptors are formed, which bind to these orbital fibroblasts and lead to further activation of orbital fibroblasts and release of chemokines such as IL-6, interleukin-6, RANTase, and CXCL10. Now, this will lead to recruitment of T lymphocytes into the orbit. Now, the fibroblasts express CD40, and the T lymphocytes have the CD40 ligand. So this leads to further interaction of these cells, leading to further release of interleukins such as 6, 8, and 1. Now, the interleukin-6 also helps in accumulation of B lymphocytes. So basically, thyroid disease is mediated by both T as well as B lymphocytes. Again, these fibroblasts have a high level of PPAR gamma, which will interact with the PPAR gamma ligand on the T lymphocytes and further lead to proliferation of fibroblasts, hyaluronan synthesis, and adipogenesis. So there is a cytokine immune-mediated cascade of proliferation, differentiation, and adipogenesis. So when a patient presents to our OPD or clinic, we must assess the severity and activity of the disease. So for that, we have assessment protocols, the NOSPECS classification, which is now obsolete, the clinical activity score, and the VISA classification. The VISA classification stands for the V for vision, I for inflammation, S is strabismus, and A is appearance. So the clinical activity score, at presentation, we need to look for 7 soft tissue signs. So the first two are the pain, the gaze-evoked pain, and the spontaneous retrobulbar pain, which must be present for more than few seconds. Chemosis must be assessed on the slit lamp, and we must rule out conjunctivocalcisis. Then the fourth one is the conjunctival congestion, which must be present in more than one quadrant. A mere redness because of the dry eye or the congestive orbitopathy must be ruled out. Caruncular edema, we must look for plica prolapse, closed lids, and the inflamed plica. Mere caruncular redness is not given a positive score. Then lid redness, but it is sometimes difficult to assess in dark-skinned individuals, such as in the Asian population. For a positive score in the lid edema, it should be moderate to severe with festooning and overhanging of the lower and upper lid respectively. So a score of more than 2/7 is labeled as active thyroid eye disease, and less than 3/7 is labeled as inactive. Now, in a case of bilateral disease or where the both lids are affected, one must always score the worst eye and the worst lid. On subsequent follow-up, we must look for any increase in proptosis, motility, or visual acuity worsening. Now for severity, Yugogo has given a classification. We must remember the moderate to severe one as any one or more of the following. If the lid retraction is more than or equal to 2 mm, or the exophthalmos is more than or equal to 3 mm above normal for race and gender, or any presence of inconstant or constant diplopia. Anything which is less than that should be classified as the mild thyroid eye disease. And if there is presence of signs of dysthyroid optic neuropathy or corneal breakdown such as keratitis or exposure keratopathy, it is referred to as the sight-threatening disease. So the above picture is a case of sight-threatening active disease as it presented with soft tissue inflammation size and RAPD in the right eye. And the below picture is actually a moderate severe inactive disease because there are no soft tissue signs and it is inactive as per the clinical activity score with the proptosis of 26 mm in the left and 19. That is a difference of more than or equal to 3 mm. Then for the management depends upon how we grade the severity and the activity of the disease. But the initial step remains the same. That is prompt euthyroid restoration, cessation of risk factors such as smoking, supportive treatment such as lubrication, cold compresses, and lid taping. So if the disease is active and mild, then we go for supportive treatment, antioxidant supplementation such as sodium selenite oral 100 mg BD, and some local form of steroids have also been described. For moderate to severe active disease, corticosteroid therapy is the first line of treatment, with the most popular being the IVMP pulse therapy, intravenous methylprednisolone. If the patient is unresponsive, we can think of giving steroid-sparing immunosuppressants or radiotherapy. Nowadays, targeted therapy has been popularized, which is based on the pathophysiology of thyroid eye disease. Then we have the sight-threatening disease, for which we give high-dose IVMP. And if there's inadequate response, then we can go for urgent orbital decompression even when the disease is inactive. So for inactive thyroid eye disease, we must achieve euthyroid status for at least 6 months and then go for sequential surgery.
5 minutes over.
Okay, first is the orbital decompression, then strabismus, and then eyelid surgery. So that's it. Thank you.
Thank you so much, Dr. Ayushi. Ma'am, Sonal ma'am, please take.
Yeah, I wish to congratulate you for completing this such a huge topic in the given time limit, and that too so comprehensively. So would you like to, share something about the optic trial? Okay, no problem. I'll just drop a hint. So it's related to the Tepeza drug that has been given FDA approval. If you can just share something about that.
It's a teprotumumab drug, which is actually a humanized monoclonal antibody against the IGF-1 receptor, and it was FDA approved in January 21, 2020, and has been approved for moderate to severe active thyroid eye disease in adults, and it is probably the only drug which has been shown to be effective in reducing the proptosis in cases. So it is said that it is as good as decompression in inactive.
Right.
It is given as infusion once every 3 weeks for 21 weeks, and 10 mg per kg for the first infusion, followed by 20 mg per kg for subsequent infusions. It is not available in India right now.
And the cost is also prohibitive. It's like $14,900 or something. And so the optic trial that I was saying is the treatment of Graves' orbitopathy, to reduce proptosis with teprotumumab infusions. That's the name of the trial that has been, and the phase 3 results are out. So I just thought I'll see how much you are updated with it. And it came out in IGO actually. Santosh sir's article was there in August 2020 issue. So one should always check on the latest journals in the Indian subcontinent and Asian subcontinent while presenting. But I must congratulate you once again. Very, very, very comprehensive presentation on such a huge topic.
Thank you.
Dr. Avnish, if you would like to ask something.
Yeah. Dr. Ayushi, very nicely presented. I would want to ask you about the other radiological features of thyroid eye disease. If we can name up some and some signs which you can mention about.
Sir, for thyroid eye disease, we usually go for CT scan. Sir, am I audible?
Yes, please.
So on CT, we can measure exophthalmos. We draw an interzygomatic line, and a difference of more than or equal to 2, or the less than 1/3 of the posterior part of that line is suggestive of proptosis. Then we have fusiform enlargement of the muscles with characteristic sparing of the tendons. Then we have a Coke bottle sign where this fusiform enlargement actually leads to the pressure on the medial orbital wall, so such that it gives a Coke bottle appearance. And then we can also do CT pre and post decompression volumetric studies on CT. Then we have magnetic resonance imaging. These days, activity can be assessed on MRI via T1 signal intensity ratios, T2 signal intensity ratios, and the ADC coefficient, the apparent diffusion coefficient, which is seen to be increased in active disease because of inflammation. And then we have a new sign on MRI, that is the stripe sign, which was recently published 2-3 months ago. It says that the stripe is actually best visible on the T1 weighted contrast enhanced fat suppressed images. Then on MRI we can better visualize the optic nerve and soft tissue structures. Then we have ultrasound. These days we have orbital blood flow studies that we can assess, and it is seen that after decompression the resistivity index has seen to decrease of the ophthalmic artery and the central retinal artery. So there are various radiological features of thyroid eye disease. And then we have predictors of dysthyroid optic neuropathy based on radiology. We can measure the Barrett's muscle index, and then we can also see the dilated superior ophthalmic vein. Then we can look for apical crowding on imaging, and that's it. Thank you.
Thank you, Dr. Ayushi. You have kind of summed up most of the parameters and imaging which is required. Any other questions, Dr. Devakant or Dr. Nilesh? Can
There
be
are
fit in
questions.
before we move on to the next slide.
Avnish, there are some questions from the audience to her. Like 20% TD patients are euthyroid. I think Dr. Ankita is asking.
Ma'am, you can take the question. Actually, you can say the question. Sonal ma'am.
Yeah, okay. 20% patients are euthyroid. So how would you monitor euthyroid status in inactive TED patients for 6 months, as your slides have shown? That's Dr. Ankita Aishwarya who's asked that question.
Thank you for the question. If the patient is inactive and euthyroid, then all we have to do is see if the patient is still euthyroid, and then we can go for decompression. That scenario of euthyroid for 6 months is given by the UGOGO guideline, that if the patient is hyper or hypo or has a thyroid dysfunction, then we must achieve euthyroidism for at least 6 months and then go for decompression. If the patient is already euthyroid and inactive, then I think we can go for decompression if indicated.
Is there a role for minimally invasive surgeries in thyroid eye disease?
Minimally invasive orbital decompression has been described. Endoscopic decompression is being popularized. Then we also have customized decompression where simultaneous stage 1 and stage 2 surgeries are being done. Then minimally invasive, as the new approaches like caruncular approach, conjunctival approach, or the swinging eyelid crease approach have also been have also given good results.
Excellent answers. Shall we move on maybe? See, she's answered everything pretty well.
Yeah, ma'am, we should move ahead.
Sure.
So next presenter will be Dr. Milu, and I'd request Dr. Ankita to introduce.
Well, hi. Our next speaker is Dr. Milu Mohandas. She is currently a secondary DNB resident at Al Salama Eye Hospital, Balampuram, Kerala. She'll be talking on my topic of interest, retinoblastoma. All the best, Dr. Milu. Over to you.
Okay, thank you.
The lead judges for this presentation is Dr. Devakant Mishra sir and Dr. Apurva ma'am.
Good evening, everyone. Thank you, Yosi team, for giving me an opportunity for presentation. My topic is retinoblastoma. Retinoblastoma is the most common primitive intraocular malignancy of childhood, which arises from the primitive retinal cells, with an incidence of 1 in 18,000 live births. It is caused by mutations in the RB1 tumor suppressor gene, and it can present as 40% presenting as heritable diseases with associated non-ocular cancer, cancers, and 60% with non-heritable diseases without any predisposition to cancers. The histopathology is characterized by malignant neuroepithelial cells or retinoblasts that arise within the immature retina. The differentiation can be fluorescein rosette, homarite rosettes, or fluorettes. The most common clinical presentation is leukocoria, followed by strabismus, and other atypical presentations like vitreous hemorrhage, pseudohypopyon, preceptular orbital hyphema, or phthisis bulbi. A thorough clinical examination is necessary for the diagnosis of retinoblastoma, from red reflex to confirm leukocoria. Visual acuity, possibly in older children, if possible, can be taken. Pupillary reactions to be noted. And anterior segment, look for any proptosis, ciliary ingestion, pseudohypopyon, secondary glaucoma, and dilated fundus examination to evaluate the retinal mass to determine its location, the extent of the tumor, laterality, and staging. And photographic documentation should be done during each visit. Radiological evaluations like B-scan help in defining the tumor size and height and thickness, and also confirm retinal detachment and intralesional calcification, as you can see in the picture. The other one is the MRI, which helps in the initial staging and also to evaluate for any extraocular extension. Here we can see in the right eye the lesion with extension to the optic nerve and proptosis associated. So to approach a case, retinoblastoma can be intraocular or extraocular. Extraocular, it can be orbital or metastatic. Intraocular has been classified by the International Classification of Intraocular Retinoblastomas into small tumors that is less than 3 millimeters. Next one is tumors more than 3 millimeters. Then is tumor with localized seedings, tumor with diffuse seedings, and extensive retinoblastoma. Shield classification, that is International Classification of Retinoblastoma, similarly has classified into 5 groups, that is small tumors less than 3 millimeters, larger tumors more than 3 millimeters, group C with focal seeds, group D with diffuse seeds, and E with extensive retinoblastomas. This helps in the treatment, deciding the treatment protocol and also for the prognostication. So as a tumor mass advances, it can be endophytic, that is growing into the vitreous cavity, exophytic, that is behind the subretinal retinoblastoma mutation, with bilateral retinoblastoma with concurrent CNS tumors with a poor prognosis. So these are the differential diagnoses to be considered in a patient with leukocoria. So the management primary goal is to save the life of the patient, and secondary goal is to save the organ, and tertiary goal is to save the vision of the patient. Treatment depend upon the site of the tumor. If it is an intraocular retinoblastoma, the treatment modalities can be chemotherapy, brachytherapy, thermotherapy, radiotherapy, photocoagulation, cryotherapy, or enucleation. So these are the different routes of chemotherapy: systemic chemotherapy, periocular chemotherapy, intraarterial chemotherapy, or intravitreal chemotherapy, and these are the drugs used for the same. So here we can see the tumor regression following chemotherapy. The second picture showing the tumor has reduced following 3 cycles of chemotherapy. And the last picture, with the addition of the transpupillary thermotherapy, there is complete regression of the tumor mass. The newest mode is an intra-arterial chemotherapy, where there is localized delivery of the chemotherapy drugs with minimum systemic side effects. Through the ipsilateral femoral artery, the catheter is passed directly into the ophthalmic artery and the drugs are administered. We can see the regression of the tumor mass following chemotherapy. Then is a transpupillary thermotherapy, where there is tumor cell apoptosis with the help of infrared radiation done for tumor mass less than 4 millimeters of basal diameter. And plaque brachytherapy radioactive implant is placed transclearly to radiate the tumors of basal diameters less than 60 millimeters. Unfortunate patients with advanced lesions group D and D that progress with conservative treatment should undergo enucleation to save the life of the patient with minimum manipulation and long harvest of the optic nerve. After enucleation, the histopathological evaluation should be done to see for any high-risk factors like anterior chamber seedling, iris, ciliary body, or optic nerve invasion. If present, should undergo cycles of chemotherapy along with additional therapies like radiotherapy. Similarly, for orbital retinoblastoma and also for metastatic retinoblastoma, additional treatment should be given. So to decide on the treatment, if the patient is having a unilateral disease who present in the early stages, that they can be given intra-arterial and systemic chemotherapy along with focal therapies. But if the patient presents late in the unilateral case, intra-arterial and systemic with enucleation to save the life of the patient has to be done. If the patient is having bilateral disease who presents early, systemic chemotherapy is the treatment. If present late, systemic and periocular chemotherapy can be tried. Children who undergo eye salvaging procedure should be followed up for a recurrence and should be documented during each and every visit. And recurrence of retinoblastoma from treated lesions is very common and can occur years after treatment. Hereditary retinoblastomas requires a long-term follow-up and also an oncology evaluation to look for any secondary malignancies throughout the body. Thank you.
She was well within the time limit. Divakant sir, please.
Great. Thank you, Dr. Meetlu, for a very nice and very rapid fire presentation. So you have mentioned a lot of investigation. So is there any role of angiography as well in retinoblastoma?
Early lesions can be diagnosed, but if there is any vitreous seedings and all, it will be difficult to see if the ocular media is not clear.
Okay. Okay, but in cases of recurrences, if there's a scar, flat scarring type of thing, then angiography can help us, and it helps us in seeing neovascularization of the iris as well. And another question would be, you have talked about tumor regression. So after primary chemotherapy, the regression patterns that we see, there are various types of regression patterns. Do you know about some of them, the types of regression patterns?
The tumor regress mass seen as white lesions or associated scars may be present, and the recurrence can be with the vitreous seedings can be seen with the recurrence.
Very specific way the way it is described. Anyway, any questions from Dr. Apurva?
Yeah. Hi, Milu. Excellent presentation. Very well summarized. My questions are very, very simple. What is the inheritance pattern of RB? Is it dominant or recessive?
It is usually 40% are heritable diseases and 60% are non-heritable diseases.
No, heritability in heritable disease, is it dominant or recessive?
It is autosomal dominant inheritance.
Then how come you need 2 genes to get the disease?
It is Knudson's 2 hit hypothesis. When the inheritable lesions, one gene may be abnormal, and when the second hit occurs, the retinoblastoma lesions can.
Very good. So because of Knudsen 2 hit hypothesis, it is dominantly inherited, but genetically it's a recessive disease. Okay, what is the full name of Dr. Knudsen, and is he a Nobel Prize winner? True or false?
I don't know, ma'am.
Do you think he got a Nobel Prize? Just toss heads or tails.
Yes.
Yeah, very good. Done. Pass. So he's Dr. Albert Knudsen, and he is a Nobel Prize winner. So congratulations, you've answered my questions.
So, Ankita
Hello.
said that it's her favorite topic. So you want to ask any questions? She has posted one.
Yes, I've posted one.
Yeah. So side effects of EBRT in retinoblastoma patients.
Basically, Dr. Milu, do you think that it's a nice thing to give EBRT? EBRT even covers the micrometastasis. So if you have to go ahead with that, would you be going in all the patients? If no, why? And if yes, can you just enumerate even one cause, one of the situation where you would go for EBRT?
EBRT usually is considered in the late stages and can be given along with the extended cycles of chemotherapy. And the
side effect of EBRT? One side effect.
Early first treatment to be given for retinoblastoma.
Yeah, the treatment of retinoblastoma has evolved, right? From enucleation to EBRT to chemotherapy and currently to IAC. So why there was a shift from EBRT to chemotherapy? Basically, very simple question. Side effect of EBRT, do you know or not? That's it.
Neutropenia may be associated with EBRT.
That can be associated with chemotherapy. Something very severe that we always try to avoid. Or we are like always, whenever we give EBRT, we're always, thinking that this should not have been done, or we try to avoid. Okay, have you heard of secondary malignancies in retinoblastoma? So most common secondary malignancy which occurs with EBRT is sarcoma, osteosarcoma. So we are always scared to give EBRT in all the patients of until unless it's very severe or it's something metastasizing of the RB, we don't give EBRT.
Okay, so I'll just ask one practical question. Dr. Milu, if there's a patient who has presented to any general ophthalmologist at a later stage and now is needing enucleation in one eye, the other eye is perfectly fine, there's no retinoblastoma in it, what is the way to counsel the patient? What is the practical way to counsel the patient regarding enucleation? The patient's parents, basically, not the patient but the patient's parents. What is a practical way? It's a very scary proposition when you tell somebody that you have to take out the eye or something. So any very helpful tip? I would not suggest anybody to mark her on this question, but it's something that would be useful for young ophthalmologists.
Initially, the patient's parents should be educated about the retinoblastoma, which is a life-threatening. The management primary goal itself is to save the life of the patient. So even though the other eye can be also affected, the parents should be educated about that the life of the patient should be saved than the eye.
Yeah, okay. So basically, I was getting at one very simple thing that what you've said is all absolutely spot on. One simple way is also, telling the patient, putting, one hand over your own eye and telling them to put one hand over their own eye as well. A simple way to counsel is that even though after removal of one eye, if their one eye is covered, they can still see a lot. There's just a 30% field loss and, depth perception, and although they would not get into those nuances of vision, but you can at least show them that the child will still be able to see and walk around, and it's a very simple way that many times is used to counsel the patients. They get very scared that you have to take out an eye, and it's a very simple way to just tell them that okay, yes, he will still be able to see with one eye. It's not apart from the life-threatening part, obviously, that you've answered very well. So congratulations on your comprehensive presentation once again.
Thank you, ma'am. Shall we move ahead, or any judges want any other question?
I think we should move on.
Okay, thank you. Thank you, Dr. Milu, for the presentation. We will just now have the next presentation by Dr. Neelam, and I'll ask Dr. Ankita to introduce.
So our next speaker is Dr. Neelam Khatwani Arora.
Sorry. Just 1 second.
Well, she is also in the core team now. She is presently final year secondary DNB in Sant Parmanand Hospital, Delhi. She'll be talking on Lasik. Over to you, Neelam.
Yes, ma'am.
The lead judges on this presentation will be Dr. Avnish sir and Dr. Karan sir.
Okay, good evening, everyone. I'm going to present all about Lasik in brief. Lasik.
Neelam, you are not audible.
Are my slides visible?
It's
slides visible, are visible, but it's not moving.
Yes, sir, it's not moving.
Neelam, what you need to do is take out that marker and switch to the cursor. Then probably it will work.
Okay, sir.
Yeah.
Yes, sir.
Or you can use the marker at the same time and use your keyboard to change the slides.
Okay, so I will go without a marker. Okay, good evening, everyone. I'm going to discuss all about Lasik in brief. Lasik, that is laser in situ keratomiliosis, which uses excimer laser to photoablate the intrastromal cornea to correct refractive errors. It is used to correct myopia till 8 diopters, astigmatism till 6 diopters, and hypermetropia till 4 diopters. We should know about these eminent ophthalmologists, Sir Ignacio Barraquer, who is the father of modern refractive surgery, and Palikaris, who first performed the Lasik surgery. Two main instruments, microkeratom and excimer laser machine, are used in this surgery. Microkeratom, it is an instrument which is used to prepare a hinged corneal flap of pre-calculated thickness and diameter. And excimer laser, it uses argon fluoride of wavelength 193 nm and photoablates the intrastromal cornea. It has a smaller wavelength, so limited penetration, minimal damage to the surrounding corneal structures, sufficient energy, extremely short pulse duration, and a good reproducibility are its advantages. Preoperatively, patient selection is very important for the surgery. Adequate globe exposure should be there. Patient with sunken eyeball a bad choice. A good corneal thickness of about 450 microns is required. Patient should be able to tolerate a high IOP of 65 millimeters of mercury. Preoperatively, pupillary size should also be measured and it should be adequate. Contact lens wearer has to be discontinued before the surgery. For the preoperatively evaluation, we should check the best corrected visual acuity, have a proper refraction, a detailed slit lamp examination to rule out any causes of dry eye, indirect ophthalmoscopy to rule out any peripheral fundus disorders, intraocular pressure by Goldman applanation tonometry, corneal pachymetry and topography by a pentacam is very important to rule out any subclinical ectasias or any subclinical keratoconus. A newer innovation, that is corneal biomechanics by ocular response analyzer or Corvus ST, is very important in deciding which refractive surgery to undergo for a particular patient. Coming to the surgical steps, it is done under topical anesthesia. A proper globe exposure can be done by a solid bladelet speculum. Then corneal marking is done for the suction ring application, and a very high IOP of 65 millimeters of mercury is required to allow the microkeratom head to pass and make a corneal flap. And after lifting up the flap, the intrastromal laser ablation is done. What we need to know that we have to cut wet and ablate dry. This will help in a proper ablation. Nowadays, femtosecond laser is used to make the corneal flap. It is an infrared laser with wavelength of 1053 nm, and it uses photo disruption. It cleaves the intrastromal cornea by a layer of gas bubbles. It further has advantages like because of a large wavelength, a wide range of flap thickness can be made, and it is very reliable, and a wide range of flap diameter, hinge length, hinge position can be done. Section is very less and there's no transient visual loss. Symptoms of dry eye and epithelial ingrowth are less with it. Femtosecond flaps are more uniform. Now coming to the complications of Lasik, there are intraoperative complications, postoperative complications, femtosecond specific complications, and inherent problems after Lasik. Intraoperatively, complications with each surgical step, complications can occur like ranging from conjunctival chemosis due to the suction ring application, then corneal flap related complications like flap perforation, free cap, buttonholing, or during intrastromal ablation, decentered ablation, irregular ablation, or hinge ablation. A poor flap repositioning can lead to flap wrinkling or interface deposits, and even flap dislodgement during the removal of the eye speculum. Then a range of post-operative complications like poor adhesion, flap loss, infectious keratitis, diffuse lamellar keratitis, central islands, astigmatism, halos, glare, corneal ectasias, dry eyes, loss of contrast sensitivity. Coming to the femtosecond specific complications, an opaque bubble layer can occur, transient light sensitivity syndrome, rainbow glare, diffuse interstitial keratitis is more common with femto laser. And there are certain inherent problems after LASIK, like this is underestimation of IOP and inaccurate IOL power calculation and difficult contact fitting post LASIK. Newer innovation is customized LASIK, that is C-LASIK, which uses wavefront aberrometry and corneal topography guided ablation. The advantages of this customized LASIK is that we get a very high quality vision free from night glares and halos because it takes care of all the spherical aberrations which occurs with the conventional LASIK, and there's improved contrast sensitivity, supervision of about 6:4 or 6:3, less invasive, and it can correct irregular astigmatism also. Thank you, sir.
Judges, please note she was well within time limit. Avnish sir and Karan sir, please take over.
I think Dr. Karan can ask questions, then I'll come to the remaining part. Dr. Karan, if you can please ask.
It was an excellent presentation, Dr. Neela. I have a couple of questions. You just touched on this topic a little bit, but what is the difference between the flap of microkeratom versus a femtosecond?
With the microkeratum, we get a meniscus shaped flap, and with the femtosecond laser, we get a very good flap. And the complications like the epithelial ingrowths, these are the epithelial ingrowths or any epithelial aberrations, they are less with the femtosecond laser as compared with the microkeratum laser.
So partly you were correct over here. So the femtosecond, as you have said, is a meniscus flap. Okay, so it is thinner in the center and it is thicker in the periphery. But it is the word is a planar flap in case of when you're using a femtosecond laser.
Yes.
And the other point is there are always errors. So around 20 to 30 microns of errors have been seen plus minus when you're using a microkeratome, and comparison to about 6 to 10 microns when you're using a femtosecond laser. Okay, so another question is, can you talk about little bit about, have you heard of the term percentage tissue altered?
Yes, this percentage tissue altered decides about the post-Lasik corneal ectasias which can occur if a percentage, it has been found in few studies that if percentage tissue altered is more than 40%, there are more chances, more risk of post-Lasik corneal ectasia.
Excellent. So PTA or percentage tissue altered, as she has correct, she's very correctly said. Can you name the person or the clinician who has put this thing forward or this idea forward?
Sir, I read it in the recent IGO journal. It was published there.
Yeah, so it was my article only.
Okay.
So yes, it is described by Dr. Santiago, but the problem just for the readers is that Dr. Santiago had used percentage tissue altered in placido-based topography. Okay, so let's not go into that. So we are now using elevation-based topography. I have another question over here. So you had said that the indication for myopia, particularly less than 8 diopters, so it's a little bit variable now. So okay, so you can go beyond 8 diopters or 10 or 11 diopters also, but it all depends on your other varieties, that is the corneal thickness and also the residual stromal bed, which is extremely important.
Yes.
So another thing is, can you talk a little bit about Lasik extra? What is Lasik extra?
Sir, it includes customized Lasik, which involves wavefront aberrometry and corneal topography guided.
No.
Lasik.
So Lasik extra is actually, when there's a cornea is a little bit weakened and you have about, in the borderline topography. So what you do is you do simultaneous cross-linking also with it. Okay.
Yes.
So that is Lasik extra. I'll ask one thing that you had said is pilocarpine is put before Lasik. That is not always done.
Yes, sir, not necessarily.
And one question is, so suppose have you heard of SMILE?
Yes, sir.
So if there is a suction failure or you're not able to do SMILE, is there any software by which, or is there any, I've given a hint also, something you can do to convert it into Lasik? It is known as Circle software. Okay, so you can use that and convert it into a femto-based Lasik and then do the procedure. Last question. So you had talked a little bit about epithelial ingrowth. Is there any non-surgical way to remove it, particularly if it's small and it is easily available in our OPDs?
So by scraping, we can remove it.
You can do that, but I said non-surgical. So you can use Nd:YAG laser also at times. Okay. Very small thing. And generally, if it's an epithelial growth in the periphery, the better thing would be to just observe them. And only when they go towards the center or paracentral area, that is when you intervene. A differential diagnosis of epithelial growth is infections also. So you have to be careful about that. That's enough questions from my side. Avanish?
Yeah, I think I'll ask very simple question from all your, what do you call it, the difficult ones which I've asked. Dr. Neelam, if you can tell me what are the retinal findings, if you send a patient to a retina person, what are the findings you would expect him to rule out before making the patient fit for a LASIK surgery? So can you name a few retinal findings which a person should look into before actually making a fit for a LASIK surgery?
Sir, examination of peripheral retina and looking for peripheral retinal degenerations is very important before doing LASIK, like looking for any lattice or any retinal holes that needs to be barraged before undergoing LASIK.
Anything about the macula, if you can tell us?
Yes, sir. All the macular disorders, macular scarring, this all has to be one.
Yeah. Yeah.
Any
Thank you.
macular degenerative disorders, macular scarring, this has to be.
Yes, if you have to rule out any macular diseases which are present, you can always try to do at times in OCT to rule out. Sometimes the
Yes,
patients will have an hematoma sort of a thing, or maybe too much of a colorectal atrophy at the macula. So we need to explain those patients about the condition and then again go ahead with the surgeries. Thank you. Thank you, Dr. Neela. Thank you.
I'll just ask one more thing is, I don't know if the slides are moving pretty fast. So I'll just comment on it rather than ask a question away. So when you're doing LASIK, it's very important to check for dry eyes. Okay,
Yes,
if any dry eyes is going to worsen. So do a Schirmer's and a T-Butt, and these things are very essential. And if a patient has dry eyes, it's going to worsen post LASIK or any refractive surgery. So that is a relative contraindication for doing any cornea-based refractive surgery.
Yes, sir. I have already mentioned.
Yeah, I just wanted to add that. So yeah.
Sonal ma'am had one question, sir.
So would you like to say something about transient line sensitivity syndrome?
Post transient light sensitivity syndrome is mainly seen post femtosecond laser. A patient has photophobia for a few days because of the inflammatory reaction of corneal keratocytes due to those infrared rays and the gas molecules. The patient has a little photophobia.
Now, how do you treat it?
Now we can alter the frequency of the application of femtosecond.
A patient has developed the so-called transient light sensitivity syndrome. How do you treat it like now? When do they usually present with this?
Ma'am,
so the treatment is very simple. The topical corticosteroids are given for it, and they would generally be presenting in after the first week, generally in the second week that they start presenting with this particular issue. Am I right, Karan?
Fine, and brimonidine also helps. I'll just just answer the questions in the thing. So there's a question regarding any indications for LASIK in less than 18 years. There is a study. It was done in Assam only regarding for pediatric age group, but generally the thing is that it is not recommended less than 18 years of age, and the power has to be stable. Muskan had asked that using wavefront optimized or guided. See, it depends on personal choice also. And in what I have read and learned about is, it doesn't matter, even standard LASIK is good enough. People will differ on this point because there is a concept of changing the normal aberrations of the eye. So if you do a standard LASIK, and if, that's fine. If you do something else and you change the aberrations that the patient is used to, it it makes the patient uncomfortable. So these are controversial topics. Regarding a nasal or temporal flap, actually it's a temporal and a superior flap. Anything is preferred. Different machines or different blades give different options regarding that. So I think we can go ahead now. Yeah.
Thank you, sir. Thank you, Dr. Neelam, for the presentation. And we have our next presenter, who is Dr.
Excellent
Niharika.
presentation, Neelam. Keep it up. Excellent presentation.
Thank you, sir.
So next presenter is Dr. Niharika. Dr. Muskan, please introduce.
Good afternoon, everyone. It's my pleasure to introduce Dr. Niharika. She has done her MBBS and DOMS from JN Medical College, Belagavi. She is currently final year secondary DNB resident in Netradham Super Speciality Eye Hospital, Bangalore. And she is going to present on the topic antiviral drugs used in ophthalmology. So all the best, Dr. Niharika.
Thank you.
And Dr. Karan and Dr. Digvijay sir are the lead judges for this presentation.
My video was not working from the system, so I'm using the video from another device and sharing from other device. Are my slides visible?
Yes, they're visible.
Okay. Good evening to all. I'll be presenting on antivirals in ophthalmology. So I'm starting now. The viruses can be classified into either DNA or RNA virus depending on the host cell. They depend on the host cell for their metabolism. And the viral enzymes and proteins are the most effective molecular targets for targeting these viruses. And they are the antivirals are actually either analogs of purines or pyrimidines, and currently available drugs, they inhibit viral nucleic acid, and they are only active on the actively replicating cells and not on the dormant cells. So as the virus enters the cell, there is entry, penetration, uncoating, and then protein and nucleic acid synthesis. Then again, packaging and assembly of the virus and release. So the drugs we are discussing here, they'll act on the nucleic acid. There are 9 FDA-approved drugs which have been proven to be efficacious in ocular viral diseases. My slides are okay. 6 of them are currently being used. I'll be discussing them. They are acyclovir, valacyclovir, famciclovir, ganciclovir, cidofovir, and foscarnet. Coming to the mechanism of action of various drugs, acyclovir, valacyclovir, famciclovir, as well as ganciclovir, they need to be activated by viral thymidine kinase for being in an active form. And acyclovir acts by competitively inhibiting the deoxy-GTP of the viral DNA polymerase and also by chain termination by incorporation into viral DNA. Valcyclovir also has the same mechanism of action because it's a prodrug of the acyclovir. Famciclovir also acts by competitive inhibition of viral DNA polymerase, but there is no chain termination here. Ganciclovir, it acts by competitive inhibition of viral DNA polymerase, whereas foscarnet and cidofovir, they don't require any activation by the viral thymidine kinase, and they also act by inhibiting the DNA polymerase. So summing up what I told right now, acyclovir, penciclovir, and ganciclovir, they need to be activated by the viral thymidine kinase to convert it into monophosphate, and then subsequently by host kinase to be converted into the diphosphate and triphosphate form. And finally, they act on the DNA polymerase. Whereas trifluridine and cidofovir, they don't require to be activated by the thymidine kinase and only activated by the host kinases. And foscarnet, that directly inhibits the DNA polymerase. So whenever there is a mutation and there is a resistance to acyclovir and ganciclovir, we can be using trifluridine, cidofovir, or foscarnet in such situations. So coming to the clinical uses of these drugs, the most commonly used is for herpes simplex virus. Here, previously they were using trifluridine drops, 1% every 2 hourly, which is not used currently. Vidarabine is also only available through compounding pharmacist. Ganciclovir, it's available in topical gel form, 0.15%, and to be used 5 times a day. Acyclovir, it can be used as an ointment, 3% 5 times a day, or oral treatment for 400 milligram 5 times a day, and for prophylaxis 400 milligram BD. Valcyclovir, it is used 3 times a day as 500 milligram for treatment and once daily for prophylaxis, and the dose is half for famciclovir than valcyclovir. Acyclovir for herpes zoster, the topical form is same as for herpes simplex. For oral treatment, the dose is doubled in all the drugs for herpes zoster infection. Coming to the antivirus for CMV retinitis, ganciclovir is the most commonly used drug. For IV doses, there is induction and then maintenance. Induction is 5 milligram per kg 2 times a day, followed by a maintenance dose, which is once daily for the same 5 milligram per kg. Induction has to be done unless the host is immunocompromised or CD count is not till 100. After that, we can use a maintenance dose. Intravitreal 200 to 2000 microgram is used once in 2 weeks. And oral form for 500 to 1000 milligrams 6 times a day can be used. There is also intravitreal sustained release implant, which releases drug as 1 microgram per hour. And it is effective for 6 to 12 months. And after that, a new implant has to be put. Foscarnet can also be used, IV induction dose for 60 milligram or 90 milligram per kg, and maintenance dose for 90 milligram per kg into divided doses. Cidofovir can also be used for induction and then maintenance. All the drugs are, as they are virostatic, they have to be used for induction and then subsequently for maintenance doses. Valcyclovir is also a prodrug for ganciclovir, and then it has to be used 900 milligram 2 times for induction and 900 milligram once daily for maintenance. Coming to ganciclovir intravitreal implant, which is to be administered in CMV retinitis patient, mainly we use it for zone 1 disease or a recurrent disease. The implant has 4.5 milligram of drugs, and it maintains the level of 4 microgram per ml and releases the drug at the rate of 1 microgram per hour. It has to be surgically implanted into the vitreous, and it has to be sutured to the sclera actually. This photo shows the implanted ganciclovir in the eye, the sclera.
5 minutes over.
Okay, here are my references. Thank you.
Karan sir and Divya sir, please take over.
So that is well presented overall. So what is the most common, opportunistic infection that you would get in patients with AIDS, and what would be your drug of choice, antiviral drug of choice for that?
For CMV retinitis, and that is through hematological spread which comes to the eye, and the drug of choice is ganciclovir there.
And among all the antiviral drugs that you have mentioned, which of these drugs is not suitable for the intravitreal route, or in fact, out of the ones that are typically used for CMV retinitis?
Sir, here, Val ganciclovir is actually, it has to be given orally. We can't give it through intravitreal or intravenous because it is more bioavailable when absorbed by the gut actually.
Ideally, wouldn't it, if it is given directly, wouldn't it make more sense to take an effect? Why can't it be given intravitreal? Essentially, what is the difference in?
It has to be absorbed through the gut because of the first pass metabolism and more availability from the systemic absorption rather than intravitreal. It won't be effective that way.
Right. I mean, actually, it has to do with the the structure and the way. So they've that and other drugs such as cidofovir also they've started to use it now. Liposomal preparations, but the idea is it has to be lipophilic to get through that.
Lipophilic, and it can be given. Cidofovir can be given intravitreally in 20 microgram doses. It's mainly for prophylaxis in HIV patients. Not usually.
Yeah. So can you talk a little bit about the HEADS 1 and the HEADS 2 study?
HEADS 1 and HEADS 2 the landmark studies for herpetic diseases. In HEADS 1, there had been 3 therapeutic trials, and in HEADS 2, we had 2 preventive and 1 epidemiological study. So coming to HEADS 1, basically it's about the addition of corticosteroids to see topical corticosteroids. They had used prednisolone phosphate, and they had seen if it's effective in epithelial keratitis, stromal keratitis, or iridocyclitis. So basically, there is no role in epithelial keratitis, but it is effective in stromal keratitis as well as iridocyclitis. So coming to the prevention trial, when we give oral acyclovir in epithelial keratitis or stromal keratitis, and one arm had epithelial keratitis and one had stromal and iridocyclitis. So basically, it won't stop the progression of epithelial keratitis to stromal or iridocyclitis. So we should not be giving that. But it does prevent the recurrence in cases of stromal keratitis, iridocyclitis in the further events. So for long-term prophylaxis, it has to be given. And then there is an epidemiological study in that actually there were a less number of subjects, so not very credible, but they have found that the stress factors are not associated with recurrence of herpetic eye disease.
Good. So what you've done is, in the exam, if it is asked, a better way to present it would be HEADS 1 you class separate and HEADS 2 separate.
Yes, sir.
I'll just say the points that are sufficient is that the thing is that you have to give topical steroids when you're getting stromal keratitis in conjunction with a topical antiviral. Okay. The role of oral acyclovir in cases of stromal keratitis is not required when you're already giving a topical antiviral. However, for iridocyclitis, you have to give it. As you had said, epithelial, also the cases of epithelial diseases, what happens is it's not required. You do not need to give oral. There's no psychological or risk factors. However, for maintenance therapy, you need to give. So my next question to you is, how long do you give the maintenance therapy? Particularly, yeah.
So usually it's given for a year or so, but if the patient is immunocompromised and they are getting recurrences, we have to give for lifetime also. If they are getting more than 2 recurrences per year.
Very good. So Very good. So another question that I will ask is, what's the question I have written? Yeah. So topical acyclovir. Okay. So when you're giving, it's generally given up to 2 weeks. Okay.
Yes.
So it's 5 times a day. Everybody knows that. But when it's not written in literature, but people make it BD or TDS for longer duration. But what is the problem with acyclovir that you stop it at 2 weeks? And what is the advantage that ganciclovir gel has over acyclovir ointment?
So basically, the gel form doesn't even the first
See,
of
I'm a
all.
cornea surgeon. I'm asking you related to the cornea. That's a big
Yes,
hint.
sir. The gel form will not even obscure the vision of the patient. That is one. And the acyclovir, there can be resistance to the drug over
Something
time.
related to the epithelium.
Yes, sir. It's epitheliotoxic also.
Yes.
It will.
So yes,
it will cause
absolutely.
some acyclovir, if we use for longer time, it will itself cause some subepithelial erosions and
Not epithelial erosion. That is just, you had correctly said, it is toxic to the epithelium. So
even
toxic to the,
conjunctival hyperemia, limbal hyperemia, and edema. All this happens with that drug. So ganciclovir doesn't cause that. So it's a better choice for topical.
one more question to you. Which topical antiviral had they used in the heads 1 and heads 2?
Sir, there they had used trifluridine.
Very good.
And that is not used now because of that thiomersal preservative and more side effects of it.
So, okay, last question I'll ask you is, a lot of studies that come from the US, okay, they talk about, they do not mention acyclovir that much, topical acyclovir. Do you know the reason?
It's not used there. Sir. It's not available.
It's rarely available. That's a bonus question. That is the reason it's very difficultly available in the US. For us, it's available.
That's why in the study also they had used trifluridine only.
Yes. So even the thing is, that's why they use oral, and oral actually does work also. But heads 1 and heads 2 are shown. That's all the questions from my side. Excellent presentation, Niharika.
Current a few questions.
There is chat also. So the chat questions are just coming to that. So there are two questions. One is, what are the contraindications for valganciclovir and blood tests that you would need to do, and what would be the ocular side effects of cidofovir?
So cidofovir ocular side effects are not much. Only most of the antivirals, they have this same like epithelial toxicity and allergy, and then they have the renal impairment, which is more important in systemic cases. So we have to, all these drugs are excreted through the renal route. So GFR and even serum creatinine has to be monitored, and dose has to be adjusted if any such problem exists in the patient. And even in cidofovir, they can have neutropenia as well, like ganciclovir.
That is, I think, partly true. Kaushik, you wanted to add something to that?
Actually, cidofovir can cause severe uveitis, hypotony, and endophthalmitis.
Ocular hypotony also. So that's why we don't even give this with along with ganciclovir implant, because it will again cause hypotony in such patients.
And also for ganciclovir, you have to ensure that platelet count is not
Platelet count. Yes.
not less than 25,000, and absolute neutrophil count is not less than 500, and hemoglobin should not be less than 8. Also, there should be no very severe renal compromise. So it can cause troubles later. Okay, thank you.
Okay, thank you.
Divya sir, can we move ahead, or any more questions?
Yes, no, we can move ahead.
So coming to last presentation of today, that will be Dr. Shrungari, and I'll ask Dr. Muskan to introduce Dr. Shrungari, please. Just 1 minute.
Our next speaker is Dr. Shrungari Vaghela. She is currently working as a senior resident at Government Medical College, Surat, Gujarat, and she's going to present on the topic corneal drawings. All the best, Dr. Shrungari.
Thank you.
The lead judges for this presentation is Dr. Karan sir and Dr. Sonal ma'am.
Good evening to everyone. Today I'm going to talk on the topic of diagrammatic representation of cornea and its various pathologies. So what is a corneal drawing? It is the diagrammatic and schematic representation of the different types of corneal pathologies. In this talk, I'll be giving you insights on the history of the corneal drawings, the basics of the corneal drawings, and especially the color codings, different examples of the corneal drawings, and finally the take-home message. So the concept of corneal drawings was first introduced by Dr. A.J. Brown in 1973, wherein he introduced a system of hatchings and shadings to demonstrate the different corneal pathologies. And he also introduced the color coding, which was but very minimal in amount. So it was further modified by Dr. George O'Waring in 1977, where he elaborated further on the different color codings, and he abolished the system of hatchings and shadings. And it was further improvised by Dr. Rao and Equavella in 1986, the method which we use presently, in which he introduced the system of drawing eyelashes, eyelids, and lens in the slit view. So now what are the basics of this concept? So corneal drawing has two components, the frontal view and the slit view. So in frontal view, first of all, we'll be drawing the corneal limbus, and we'll draw the four main quadrants, and the pupil will be drawn in the center, which will act as a reference point for the sketching of the further corneal pathologies. So then we will take the different measurements on slit lamp, and we'll sketch the pathologies quadrant wise and clock hour wise. We'll outline the different opacities, and then we'll further elaborate into whether they are scars or degenerations or infiltrates. And then any abnormal vessels or pigments or folds or deposits, if any present, they'll be sketched. And lastly, vital staining will be done. And any pathology, if detected, it will be documented. Coming to the slit view, it is the optical section passing through any particular area of the frontal view. It will include the iris, lens, anterior chamber, eyelids, eyelashes, and the tear meniscus. So on slit view, when we are making a slit view, we will draw two parallel lines on the frontal view, which will depict the exact location of that particular slit. So first we'll outline any variation in the corneal thickness, if any, as in stromal edema or corneal thinning. Then we'll go on to sketch the lesions of epithelium, followed by stromal pathologies, followed by endothelium, and lastly any other anterior segment pathology as in hyphemia or hypopyon. Now coming to the most interesting part, the color codings. Coming to the black color first. A black color is used to demonstrate the corneal degenerations and dystrophies, any peripheral corneal nerves, any corneal scarring, and the depth of which it is elaborated in the slit section. Any corneal foreign bodies, any guttate are shown in the slit section, either on the epithelium or on the endothelium respectively. And the bandage contact lens is shown by the dotted black lines, as we can see here. So black color is also used to demonstrate the sutures, as you can see in this optical keratoplastic picture. And any loose suture is shown by circles surrounding that suture. Coming to the brown color, it is used to depict the outline of pupil in the frontal view and the iris and the pupillary aperture in the slit view. Then any peripheral anterior synechia or peripheral iridectomy is shown by brown color, and any pigmentation over the epithelium or endothelium is shown by brown color. Coming to the blue color, it is used to demonstrate the stromal edema mainly, and epithelial edema, epithelial bullae, etc. are shown by blue circles, and the descemet membrane folds are shown by blue wavy lines. Coming to the green color, it is used to outline mainly the epithelial defects and the fluorescing stained lesions, as in the dendritic lesions of the herpetic keratitis or the superficial punctate keratitis. Any vitreous prolapse into the AC and lenticular opacities as well as IOL are shown by green color. Coming to the yellow color, any infiltrates or exudates are shown by yellow color. Hypopyon is shown by yellow color, as we can see in this slit section. And the keratic precipitates are shown by orange color. Lastly, the red color, it is mainly used to show the blood vessels. As in the superficial vessels, they can be demonstrated by branching wavy lines which cross the limbus. The deep vessels are shown by straight lines arising from the limbus, and the ghost vessels are also shown by intermittent straight lines arising from the limbus. Any ocular surface lesion which stains with the rose bengal is also shown by red color, and hyphemia is also shown by red color. The tear meniscus and its disorders can be depicted in the slit view, as it can be seen here. Any clear meniscus and any demonstrable pathology, as in purulent discharge of foamy meniscus, can be shown. Now we'll have a look at some specific disorders.
So this is the image of a corneal ulcer wherein I've shown the superficial vascularization. The defect of the ulcer is colored in green, and the infiltrates are shown in yellow, and as well as the hypopion is shown in yellow. And the mild iris hue it can be seen. Next is the pseudophakic bullous keratopathy, wherein the stromal edema is shown by blue color. There is an increase in the thickness, which is shown in the slit view, and the epithelial bullae and edema are shown by blue circles. Next is the corneal opacity, where the scarring has been shown by black color, and the superficial vascularization is shown. Next is this case of aphakia, wherein there is a vitreocorneal touch, and the vitreous can be seen on the slit section, and the localized area of corneal edema can be depicted. Next is a case of a failed keratoplasty, where we can see that the graft-host junction is well opposed. There is an epithelial defect, and there are multiple stromal infiltrates. The pupillary margin can be seen hazily, and the superficial vascularization is also demonstrated here. This is a case of a corneoscleral tear with iris prolapse. I have demonstrated the shallow AC in the slit section, and there's a tear-shaped pupil, and there's an iris prolapse from the tear side. This is the figure of the corneal tear with 5 sutures and the surrounding corneal haze, and this is the case of a polar cataract shown in green. Now, what are the advantages of having a corneal drawing? That it is helpful in daily documentation of the changes which occur in the lesions, and hence the follow-up becomes easier. It is very much mandatory for the medical legal cases. It is helpful in highlighting those details which are difficult to photograph on a slit lamp photography, and also improves the biomicroscopic skills and monitors the observations of the ophthalmologist in the training. So the take-home message here is that although this is an era of the high-tech slit lamp photography, but it is important for every young ophthalmologist to be well versed with the correct technique of corneal drawings. These are my references. Thank you.
Judges, please note she was just within the time limit. She has not crossed the time. So Karan sir and Sonal ma'am, please.
So, Dr. Baghela, would you please tell us about the Indian contribution to this particular field of corneal drawings?
Recently, an article has been published in the IGO about this.
Okay.
The authors are it has elaborated on the same specifications.
No, actually, I was going on the history side, basically, okay. Where you've given credit to
yes,
Dr.
Dr. Rao was the one, and the latest one which we follow.
Not latest, I'm first right now at the history parts. If you would have anybody there, if you remember anything on that sort, there?
Nothing, no contribution. I don't remember anything about that Indian side of contribution.
Okay, so just a small pointer for you here. You've presented everything very well, but just have a look at this particular contribution from India. This is Dr. Madan Mohan and Dr. Mukherjee, who had a publication on documentation of corneal disorders in 1980, although it's a very old thing, but this became, a part of the corneal drawings in RP Center for a very long time, and it was this particular scheme in which they drew two outer circles and then 2 inner circles, and the 2 mm square area squares were made. This particular scheme became quite popular all over India for a very, very long time. And after that, you've already mentioned Dr. Rao. So that's all that I just wanted to take your attention to, because whenever we are presenting something, we need to know if at all there is some Indian contribution on that side as well, because it was copied in a lot of eye centers all across India, though the scheme that you have presented is much more simpler and easier to present, and most of the people are following the simple 6-color pencil scheme only. So congratulations. Over to Karan.
Yeah, excellent presentation, a wonderful, wonderful slides by the speaker. And, it should be, every resident and every fellow or every consultant, everybody should be using these color codings because they are extremely important. A couple of pointers that I would like to give are that the lens is not always drawn black. A clear lens would be drawn with green color. If it's a cataract, you would color it inside. If it's an IOL, you would draw that with black color.
Okay, sir.
There are variations across different systems, but this is what we were following. Am I audible?
Yes, sir. Yes, sir.
Yeah. Yeah, and see, suture also, there's a variation. I'll give that to you. But suture, as you had said, line in a circle. So some of us draw it just as a loose round, like oval shape or something to depict loose sutures. A good idea would be, I always tell my residents that do not draw the pupil in case of corneal diagrams. So there can be variations over here because they can be confused with some sort of a dystrophy or an opacity or something, even though it's dotted lines that you have shown. I prefer that you should not do that. And see, as I said again, I'm saying there can be variations in the systems,
Yes,
and it's actually not standardized anywhere. Different hospitals follow differently. So I always tell them, draw a section at the level of the cornea separately, draw a section at the level of the iris plane separately, and that way you can get a better idea of how it's proceeding. Can you just show me your old slide, just slide on the ulcer?
Yes, sir.
So till that time, I'll add another point is that there's a different presentation for the new and the old KPs also. So one is brown and the other one I think is black or something. I've forgotten that, but you need to tell. So old and new KPs are depicted separately. So yes, can you just put full screen for this? Yeah. So again, as I said, there are controversial situations and variations, but I prefer that my residents draw the ulcer with the yellow and outline it with the green. You follow what your consultants tell you to because they'll be taking your exam. But because the reason for that is that the ulcer description is more important than the size of the epithelial defect. There can be patches in the middle where the ulcer may not be present.
Yes,
Or it may be present. So the ulcer is more important than the epithelial defect. The epithelial defect can be shown also, but I would suggest like this. One more thing is that as you have seen over here, the slit has been drawn. So this is one way to do it. The other way of doing it is that you can draw dotted line, and that is the area where the section has been drawn.
Yes,
Apart from that, an excellent presentation.
What is the diameter of the circle that you are using here?
Generally, it is written that we are supposed to draw 35 circle, but because we are in a hurry most of the time, so we just draw freehand, or we can keep a stencil for special such cases, or we can keep the pencil sets at our slit lamp, so we can be quick at drawing it.
Right, very right. And what about ghost vessels? How do you depict them?
Ghost vessels are shown by intermittent red lines, and they are radial, arising from the limbus and parallel to each other.
Right, very right. Absolutely right.
One more thing is this: in the slit section, you've drawn the iris as black. It is drawn with brown.
Yes, yes.
Yes.
In one I have a few mistakes actually.
Apart from that, it's good. One more, I would just give you that when there's a shortage of time, you should stick to more to the point rather than you put a lot of time, even though you were just on time. But just in case you exceeded, it is better you should have not focused too much on the history and rather than on what was the topic at hand.
Yes.
That's it from my side. But excellent.
Thank you,
sir. Shall we move ahead now, sir?
Yes, Nilesh.
Please, and just give me about 2 minutes to grade the 3 presentations because I was judging and
yes,
give me 2 minutes to just put the marks.
You please mark. Meanwhile, Dr. Devakant sir will start the audience poll.
Perfect.
Yes. So I think you might all be aware about the polling facility that we have on Zoom. So I'll be launching the poll, and it will be open for exactly 1 minute from
Do
now.
we also have to participate in the poll?
Yes, all of us can vote. No issues. Everybody can vote. Everybody present on Zoom. And otherwise, the voting is still on YouTube. So others who have not been able to join on Zoom can vote there as well. So I'm launching the poll now, and Nilesh, you can keep time. We'll close it in 1 minute, right? You want more time for this? Probably 2 minutes. We'll take 2 minutes. I think you can see the poll on your screens. Just, yeah, people have started voting.
I don't think so. We need 2 minutes. It's
Yeah,
like
yeah.
within 50 seconds we will have the complete polling. Already 65% voted.
7 people can still join on Zoom, I guess. We have 93 now.
Yes, we'll take in more people. Nilesh, keep adding people.
Yes, sir.
70% people have voted. So a smart strategy would be that people who have voted can log out and let others log. One minute is done. 80% have voted. So
Last 30 seconds.
yeah, just take a screenshot of the polling.
Yes, sir.
Another 10 seconds to go. I think almost all have voted. So
Yes, sir. 97% voting has been done. So we can start. We can stop at 2 minutes.
I'm going to take a screen.
100%.
So we are in, yeah, 100%. So I'm ending the poll now.
We are having a dropout from the session after the voting has ended. At risk, their work is done.
So the online polls are recorded, and the final Google mark sheet will be sent to UC Secretariat. So Devakan sir can tell us when the final results will be out.
As I have posted on the group, we are having our annual event in collaboration with the All India Ophthalmic Society. So that will be January from 5 o'clock onwards, and on 17th from 9:30 onwards to approximately 3:30 that day. So on 16th at around 8:30, we'll be having our annual award sessions. So the best EO slide, best YouTube winners, and all the other awards will be declared then. So I request all of you to join on around 8:30. We'll be sharing the link, of course, in due course with everyone.
But that said, I think all the people who reach the finale are in fact winners. I mean, it's wonderful slides. You've all put in a lot of effort. A big congratulations to Nilesh, the entire team of your slides, and all of you. It's been we can see the kind of effort that has gone into getting it here. And thanks for having all of us on the panel here as well. And a big thank you to the audience in that front. And I suppose the biggest pat on the backs to all the presenters. It was, all of them were wonderful. We were discussing on the group, WhatsApp group on the side that, it's like everybody's on fire and it's so amazing. So we like the enthusiasm. It was very nice. And Nilesh, well done.
Thank you, sir. Thank you so much for joining and being a part of this panel. I would like comments from all the judges. A quick word from everybody: Dr. Sonal ma'am, Dr. Devakan sir, Karan sir, Avnish sir.
So I would like to say that effort has gone into presentations, and I hope that they serve the purpose in educating young ophthalmologists, and they surely will. Nilesh's venture has gone in the right direction, and it's bringing good results. And congratulations to all the participants, because as sir has already said, they're all winners already. And the amount of knowledge that they have gained in this process, and they will keep gaining, I'm sure. And I'm thankful to Dr. Nilesh for involving me in the process of judging, and thus brushing up on a lot of topics which maybe we've not seen here since long, because of our involvement in whatever subspecialty that we are working in. So it was very interesting to see all this hard work that has gone into presentation.
So excellent presentations by all the speakers. Their slides are phenomenal, and everybody has said that. I just said the questions are a bit tough, and some of them were a little bit fellowship level rather than residency level, because your slides were so good. So it was very difficult to actually differentiate between everybody because their slides were excellent, and that's the reason these questions were asked, because you guys did an excellent job, and it was very difficult to differentiate between you guys. Thank you.
So Nilesh, great job. And one suggestion that I have, that all the Yo Slides winners and other participants can also record their presentations, and Dr. Karan can help us in uploading them on YouTube. So they'll become like recorded lectures. So that can be an extension to Yo Slides.
Yes, sir.
The other thing is the tremendous job on part of Nilesh and whole of the core team. They've done a great job, and great to see new faces getting involved with EOC, and great presentations. And as Dr. Sonal was saying, it was a good thing that we didn't have too many retina topics, probably not a single one. So it was good to hear other topics and other subspecialties. We tend to miss out on such presentations. So congratulations to the whole core team and all the presenters. Great job.
Thank you so much, sir.
I would like to say just one more thing. I forgot to congratulate Nilesh for the great work that he's been doing, and his team. You guys are phenomenal, and kudos to you guys. Keep up the good work. One suggestion I would give. Sorry, it broke up a little bit. Thank you, Nilesh. But and one more thing that I would like to add a bit is that in the slides when you're putting it, because these slides are particularly meant for exam-oriented people, right? So when you have put a picture, my suggestion would be to put next to it a hand drawing that you would draw in the exam, an easy drawing, because in terms of marks, it's the hand drawings and the flow charts that get you marks rather than the written content, more than the written content. Nobody's going to read your paragraphs. So these are the points. And one speaker had used an outline in their presentation. So that outline, if you give in the start that you will be talking about this in the start of your presentation, or even your answers in the exam, that would, impress the examiner beforehand only.
Thank you, sir. Excellent suggestion, and we will make sure that the further review take place with. We will insist on hand drawings along with the presentation. Thank you so much, sir. Avnish. Yes,
I would just like to say, brought out this initiative of patient education slides. So if in the future sometime it's possible, like maybe 6-7 months down the line, if you have good collection of slides, then you can have a competition for that as well, because that's a very, very, very much needed space. Like there are a lot of diseases about which, there should be some patient education slides in the vernaculars also. Like I don't know how much are they going to go into the vernaculars, but yes, English and some vernacular maybe can be thought of in the future.
Sure, ma'am. We will take it. The whole team will work on it, I think. Anisha?
Yeah, I think congratulations to Dr. Nilesh and the entire core team. What I understand is actually having a very good team, what brings out the best in everyone. And I think this was one of the forums where we were like the 4 people of the platform of YOSI were at the backseat, and we were actually literally enjoying the program because it was so smooth sailing. So as I do run a couple of programs, so I know it's very hard to organize something like this, and there are a lot of things which can go wrong. So actually, congratulations to everyone, and definitely the participants. That is what brings out the best in everyone. That was so competitive, and plus it was actually pretty good, and looking forward to more of these. And thank you so much for having me on board. Thank you. Thank you.
And I would like to hear from the other core team members about their experience of organizing this event. Ankita, you are there. So
Yes, I'm there. Okay, so first thing, thank you, Yossi, and thank you, Dr. Nilesh, for putting up this concept. I always wanted to enter the Yossi and think this was the first way where I can enter it. I'll definitely try to give my best so that, we can reach even further heights with this. Recently, I've reviewed also one. It was really interesting to understand because it not only helps the presenters, it also helps the reviewers to learn more, to understand, and also to implement in the future. So it's a very nice concept, not only for the students, for all the, I think, postgraduates, even those who are on the initial years of fellowship, they all will be benefited with this for sure. It's a very nice and one platform. In fact, I was discussing with Dr. Nilesh also that if possible, we can launch our Facebook page also, so that all the slides and everything are kept in one page, and if they want to see whenever they want to go back, and they can correlate there. So it's a very nice initiative, sir. Thank you so much.
Others, Dr. Abdul?
Hi, sir. This is my first experience. All the presenters were really good, sir. And I was not in the core team for this session. I have recently joined. So I'll be looking after work guided by Dr. Nilesh. As Ankita ma'am has already told that I wanted to join UOC. I'm a member of UOC, but this UOC slide will give me a push in my academics as well. Hope looking forward to work for UOC, sir.
Are other co-members there, Nilesh? We can hear from them.
I think so. Anybody who is on right now?
Dr. Kaushik?
Yes, I have joined recently, and actually, it's most of the works of your slides has been done by Dr. Neil under the leadership of Dr. Nilesh, and it has been executed very nicely. Actually, I have joined recently, and will look forward to doing more of this, and also to improve the quality of the slides. And also, we have divided the core people into subspecialties so that the people who are in the specific subspecialty, they look after the slides.
And we can have words from finalists if they want. How was their experience for presenting? I think most of them were first-time presenters, except Dr. Ayushi, I think. So any finalists who want to say anything?
Let's hear from the other co-members, Nilesh. I think Dr. Muskan and...
Dr. Muskan is here.
So, I just recently became the member of USEC, and I just completed my ophthalmology last year only. So I feel that it's a very good platform because there's a very good compilation of all the, like I just went through, I was not a part of this compilation, but I just went through all the slides, and I recently reviewed also one of the slides. So I feel it's a very good platform, and I will try to give my best from my side as Dr. Nilesh has divided us into subspecialties. And I feel that this is a very good initiative and a very good platform.
Welcome on board. Yeah. Anyone else, Nilesh? Can you spot?
Dr. Rakhi, is she here? Dr. Rakhi is there, Dr. Ayushi is there, Dr. Anupam is there, Dr. Neelam.
Hi. Yeah. Am I audible?
Yes, yes.
Hi, I'm Raki. I also joined the core team recently.